Ventilator Mastery Series, episode number 10, ARDS versus Cardiogenic Pulmonary Edema. Same oxygen problem, different vent strategy. Both ARDS and cardiogenic pulmonary edema present with hypoxemia and bilateral infiltrates on imaging, but their underlying mechanisms are fundamentally different, and ventilator strategy must reflect that difference. In ARDS, the problem is inflammatory injury to the alveolar capillary membrane. Fluid leaks into the alveoli due to increased permeability, surfactant is lost, and lung units collapse. Compliance is severely reduced. These lungs are stiff and highly vulnerable to villi. Positive ventilation with low tidal volumes, strict palatal pressure control, and careful PEEP titration, and often prone positioning is essential. In cardiogenic pulmonary edema, the problem is elevated hydrostatic pressure from left ventricular failure. Fluid is pushed into the alveoli because of increased capillary pressure, not membrane damage. Compliance may be reduced due to fluid, but the underlying lung structure is not destroyed. These patients often respond rapidly to positive pressure ventilation and diuresis. On the ventilator, ARDS requires strict low tidal volume ventilation around 4 to 6 ml per kg of ideal body weight, palatal pressure below 30, and careful monitoring of driving pressure. Higher PEEP strategies are often needed, and oxygenation may remain difficult despite higher FiO2. In cardiogenic pulmonary edema, non-invasive ventilation such as CPAP or BiPAP is frequently effective. One practical difference at the bedside is recruitability and response to PEEP. Cardiogenic edema tends to improve quickly with positive pressure. ARDS does not improve rapidly and requires strict lung protection. The mistake in treating both conditions the same way, hypoxemia may look identical, but the pathophysiology is not. In critical care, understanding the mechanism determines the ventilator strategy, and the difference can change outcomes.